Dr. Judith Haber is the Executive Director of the Oral Health Nursing Education and Practice Program, known as ONEP, and Ursula Springer Leadership Professor in Nursing at NYU Roy Mayers College of Nursing. Dr. Haber is a member of the Steering Committee of the National Interprofessional Initiative on Oral Health and was a member of the HRSA expert panel that developed the 2014 Interprofessional Oral Health Core Competencies for Primary Care Providers. She was a member of the technical expert panel that developed the 2015 Qualis Health White Paper called Oral Health, an Essential Component of Primary Care. In 2020, she was elected to the Santa Fe Group Board of Directors and is a member of the National Organization to Prevent Hospital-Acquired Pneumonia. She also contributed to white papers and innovations in oral health and primary care integration from the Primary Care Collaborative and non-ventilator hospital-acquired pneumonia, a call to action from NOHAP. Dr. Haber is an invited member of the Center for Integration of Primary Care and Oral Health 100 Million Mouths Advisory Board, where she will recruit and participate training with nurse practitioner faculty in 8 states to be oral health champions. Dr. Haber has consulted, presented, and published widely on interprofessional education and practice, as well as oral systemic health issues. She is the lead author of the landmark AJPH publication, Putting the Mouth Back in the Head, HEENT to HENOT, HEENOT. That's head, ears, eyes, nose, oral, throat. We thank you for that, Dr. Haber. So please help me welcome Dr. Haber.
Good afternoon. I'm thrilled to be here. This has been such an exciting day. And now we're going to continue with a clinical approach to integrating oral health innovations and managing chronic conditions, another oral systemic perspective. And I'm really thrilled to be here today. And what a day of, just wonderful presentations by everybody. Okay, so I am the leader of the Oral Health Nursing Education Program that we call ONEP that aims to integrate oral health in undergraduate and graduate nursing programs nationwide through faculty and preceptor development, curriculum integration, and establishment of best practices in oral health in clinical settings across primary, acute, school, home care, and long-term care settings. And this is our website. Check out the zillions of resources that we have for you that help not only nursing faculty and clinicians, but our interprofessional colleagues to integrate oral health as well. Next slide, please. So we believe that prevention and management of chronic conditions really calls for an interprofessional team. If you think about the size of the nursing workforce as one example, 4.2 million RNs, we are the largest segment of the healthcare workforce, including a large number and ever-growing number of NPs and midwives, coupled with our physician and PA colleagues in partnership with our dental colleagues, dentists, dental hygienists, dental therapists, dental assistants. Together, we believe that the management of oral systemic health takes our whole collective workforce contribution and impact. Next slide, please. So what do we know about chronic conditions and where patients show up? As Natalia Chalmers told us this morning, her statistics, her data were amazing, but 84% of adults have an annual medical visit. 85% of all US children aged 2 to 17 in various proportions in 2017 had an annual dental checkup. 89 million patients seek urgent care every week, but only 64% of adults have an annual dental checkup. So there is room both on the medical side to refer their patients for to establish a dental home and to include oral health preventive interventions and risk assessment and assessments in their primary and acute care practice. And in like manner, we're seeing an increased emphasis on integrating primary care, or as we could say, medical services in dental settings. And that is equally important because there really is a bidirectionality to whole person care. Next slide, please. And all too often historically, and I really appreciated Sean's presentation, Sean Boyne's presentation, but what we have found in looking at whole person care, pictographs, infographics, diagrams like this one, dentistry, dental hygiene are often left out of any whole person care or patient-centered care concept, whether it's a visual or spoken concept. It is that siloed effect once again, but we created this wheel to reflect true patient-centered care that considers the whole person and includes dentistry and dental hygiene. Next slide, please. We know, and COVID taught us this lesson all too well, that in addition to needing a whole person care team, we need one that considers the social determinants of health, which are often overriders for both oral health conditions and more systemic health conditions, and really play a major impact in accelerating progress, either positive or negative, in terms of health conditions. But these are so important in promoting oral and systemic health and well-being. We know what it means to have food insecurity, as well as poor access to healthy foods. We've heard it today about the effect of poor nutrition, and I know we'll hear it again in the next presentation, on a healthy mouth and healthy teeth. Next slide, please. We like to consider that along with temperature, pulse, respiration, and blood pressure, that oral health be considered the fifth vital sign. All too often, when even the most superficial of assessments are conducted, whether in a medical office or a dental office, the impulse, and this was especially true during COVID, where temperature was taken every place, it's almost automatic that temperature, pulse, respiration, and blood pressure are included. But tell me, how often, those of you who are non-dental providers, is an oral health assessment completed or oral health questions asked if you are completing a health history? We believe that it is as important as the other four vital signs that are an automatic part, a standard of care for any healthcare office visit in a medical setting. And vice versa, these may be vital signs, the first four, that could be considered as a standard of care in a dental setting. Next slide, please. Because in 2015, our ONEP team established and proposed that putting the mouth back in the head really called for transforming the HEENT component of the history and physical exam in medical settings be transitioned to the HENOT exam and part of the history taking, where you cannot forget about oral health. It cannot be siloed when you use the HENOT approach. Next slide, please. And the oral health delivery framework that Sean mentioned and showed on one of his slides makes it very easy to think about in a medical setting, to ask about oral health, to look for signs that indicate oral health risk or active oral health disease that we just saw in the previous presentation that was so amazingly illustrated, to decide on the most appropriate response, and to act in a medical setting to offer preventive interventions and or referral for treatment. And preventive interventions, as we'll talk about with different chronic conditions, can range from improving health literacy to coaching, using motivational interviewing, to monitoring glycemic control for diabetic patients, or treating the oral conditions that were just shown in the previous presentation. Next slide. Oh, wait a minute, before next slide, is acting. The most important thing, and probably the biggest barrier to integrated care, is documenting. All too often, our EHRs are siloed. They don't communicate with each other. They're not interoperable. And most medical EHRs do not have a required field for documenting oral health findings. And of course, we propose that that is the wave of the future and will be more evident as electronic health records become more interoperable. That is a key change that needs to become a standard of practice. Next slide, please. So basically, the oral team and the overall health team are important for addressing the oral systemic connection. We're going to talk about a few chronic conditions for which or where there is an oral systemic connection established. And there are many more that we cannot cover today, some of which have been spoken about in previous presentations today. Next slide, please. So first, we're going to talk about diabetes and oral health. Next slide, please. We know that diabetes is a chronic condition. As you'll see in the next slide, it's the 7th most prevalent chronic condition. We propose, just like we propose that oral health is the 5th vital sign, that oral health is the 6th complication of diabetes. We've heard much about neuropathy, nephropathy, retinopathy, and all the microvascular, macrovascular, vascular diseases, the ulcers that can form, the blindness that can occur, the amputations, etc. But oral health problems are an important complication of diabetes, and the one for which there is the strongest evidence base about the bidirectional relationship for that. Next slide, please. As I said, diabetes is the 7th leading cause of death nationwide. Look how many US adults have type 2 diabetes. The number is growing every year, unfortunately. Look how many, 7.3 million, are unaware that they're living with T2D, and 88 million adults 18 and older have prediabetes. 22% of them will develop diabetes within 5 years if they aren't treated. And patients with poorly controlled diabetes are about 3 times as much greater risk of developing gingivitis and then perhaps periodontitis, which of course is the oral health complication for this. Next slide, please. So, as a primarily dental audience today, I don't have to go into detail about the what patients who have diabetes are at risk for in terms of their risk for oral complications. In addition to which, on the primary care side, on the specialty endocrinology side of healthcare, there are so many medications that we prescribe that reduce saliva, leading to xerostomia and increasing risk for tooth decay. The nutrition, coaching, and counseling, the lifestyle changes we can promote that will moderate high blood sugar levels that help bacteria grow and promote tooth decay. And also for those who have any kind of ulcers in the mouth, any kind of lesions in the mouth, we know that elevated blood sugar can interfere with normal healing. And that inflammation and infection, as we've heard in much greater detail today, play a major pathophysiologic role in this bidirectional problem. Next slide, please. So, signs and symptoms of periodontal disease. This is a checklist that belongs in every primary care setting. I know it's already there in every dental setting, but it is for those of us like myself, who's a nurse practitioner, for whom this was not part of my education, that it's an easy checklist to integrate into the workflow and assessment process in your office in terms of patient assessment for oral health problems related to diabetes. Next slide, please. And so promoting oral health literacy to promote oral hygiene. Think of what Natalia Chalmers said this morning, where there's almost 9,000 hours a year spent in home oral hygiene versus probably 2 to 4 hours spent in a dental office. So that a major role that we all can play, both on the dental side and the medical side, is about keeping gums as healthy as possible through scrupulous oral hygiene to improve glycemic control and to really make sure that all patients have a dental home for regular checkups, cleanings, and any periodontal care that they need for reversible gingivitis or stabilization of periodontitis. So that coaching, using motivational interviewing about effective oral hygiene behaviors and lifestyle changes is specifically important for patients in either a dental or medical healthcare setting. Next slide, please. So here are some tips for collaboration among primary care and dental teams. These bulleted items are strategies that we all can use, whether it's in a medical or a dental setting. And one of the things I want to point out, because cost is a major barrier to obtaining dental care more than it is overall health care or specialty health care for diabetes. So partnering with trusted community leaders, faith-based organizations, frontline health team members like community health workers, faith-based churches, barbershops, hair salons, to promote diabetic health, both prevention of acceleration of pre-diabetes to diabetes, and then effective management of diabetes once that diagnosis is made, is very important. So remember, coaching, advocacy, and prevention through behavioral lifestyle changes is our goal across the spectrum, as well as referral, not only to the make sure there's a medical and a dental home, but to the other services like podiatrists, ophthalmologists, social workers, et cetera, that are effective for addressing both whole person care and the social determinants of health. Next slide, please. And at NYU, we have an interprofessional simulation experience that we conduct every year for dental, medical, pharmacy, and nurse practitioner and midwifery students around a patient who is both an undiagnosed diabetic with evidence of periodontal disease and who lost his job, has no dental home, and dramatically affected by the social determinants of health, where students learn an oral health assessment and participate in a case study discussion where they develop an interprofessional management plan. Next slide, please. We have several articles that are in the references. Okay, moving on to cardiovascular disease and oral health. Next slide, please. There is a less well-established evidence base about the relationship between cardiovascular disease and oral health. But let us say that it is the most common cause of death in the US and worldwide, and that 92 million Americans, adults that is, suffer from some form of CVD and die. Over 2,000 die each day. And I first learned about the oral systemic connection by a patient who had a root canal that ended up as endocarditis, traveled from mouth to heart, and he died. That was my first encounter with the oral systemic connection through friends many years ago. I have since learned much more about how bacteria can travel from the mouth to vital organs in the body, the heart, the lungs, etc. There was a great diagram, I think you had it, Sean, that illustrated this. But it is an important and emerging area of scientific evidence that is developing. Next slide, please. Cardiovascular disease, many risk factors: hypertension, hyperlipidemia, smoking, diabetes, much more common among diabetics, mental health clients who are on psychotropic medications, who have metabolic syndrome, and among those who are obese, which is another enormous epidemic in our country, and also affected in a major way by the social determinants. Signs and symptoms of cardiovascular disease are numerous, ranging from some that are unobservable to those like angina, headache, loss of vision, etc., that are definitely urgent and emergent, and land you in the emergency room. And then the oral manifestations can be numerous, some of which were mentioned in the last presentation. But one of the most common ways in which primary care providers and cardiovascular specialty providers can participate is being aware of the xerostomia and the multiple comorbidities that older adults with chronic conditions in particular have, where they can be on multiple medications that contribute to xerostomia that only creates a cavity-prone, bacteria-laden environment that can lead to that systemic transmission with potential for infection, or, as we learned in COVID, being a catalyst for critical infections, explosive infections in other parts of the body. Next slide, please. So again, the studies that do exist reveal chronic oral infections, pro-inflammatory markers contribute to the pathogenesis between periodontal disease and cardiovascular disease, and the fatal infections, as I mentioned. One of the most extensive bodies of evidence is related to the bidirectional relationship between hypertension and cardiovascular disease. Next slide, please. So how can an interprofessional health team make a difference? Think about cardiovascular disease as complex and multifaceted. Adults, 90% of adults 65 and older have at least one chronic condition, whether it's diabetes, cardiovascular disease, or other. It is definitely there. And this is the population most affected by chronic diseases. We heard this morning that having an older adult having 6 chronic conditions at the same time that co-occur is not unusual. And think of the number of medications they can be taking that have an impact on oral health as well. Think of the barriers related to the social determinants of health in maintaining overall health and accessing affordable dental care. We are having a meeting, a national consortium meeting at 4 o'clock about hopefully authorizing a medically necessary Medicare dental benefit that will be a godsend of sorts, more than they have now, for people with specific medically necessary chronic conditions like diabetes, those needing transplants, etc. So there is hope for overcoming some of those barriers to affordable dental care, because cost is the single most deterrent for patients to be able to, medical patients, to establish a dental home. But they can establish good oral hygiene practices. So the role of both the primary and specialty care community is that coaching about effective oral hygiene practices that can be used to manage oral bacteria levels and inflammation by coaching about good oral hygiene behaviors, because it both reduces the risk for developing tooth decay and developing cardiovascular disease and related complications. So it is important to free document oral health assessment findings, interventions, and referrals, and use of other healthcare providers like social workers to locate affordable healthcare for this population. Next slide, please. Okay, moving on to pneumonia and oral health. Next slide, please. Well, this is an exciting area. We know that pneumonia is the most common hospital-acquired infection in the United States. It affects 1 in every 100 hospitalized patients. There is an increased morbidity, and persons over 65 have 70% of the hospital-acquired pneumonia infection. There's increased mortality. It's not insignificant. They have an extended length of stay, which costs money to hospitals. There's increased cost of $28,000 to $109,000, depending on whether per patient, per episode, depending on whether they end up in the critical care unit and perhaps on a ventilator, at greater risk for ventilator-acquired pneumonia. And they are twice as likely to be readmitted in less than 30 days, which is another zinger for hospitals in terms of being dinged for ineffective care. Next slide, please. So NVHAP is a subset of hospital-acquired pneumonia that's defined as pneumonia that's developed within 48 hours of admission to the hospital without any mechanical ventilation. And a primary source of the pneumonia that's hospital-acquired is aspiration of bacteria present in the oral biofilm, where the dental plaque becomes the reservoir for pathogens, including antibiotic-resistant organisms that are present in the hospital settings. The plaque buildup, the bacterial overgrowth, along with microaspiration, when patients are bedridden, lying supine, that is flat, increases the risk for NVHAP. And I will tell you that oral care in the hospital is a thing of almost a thing of the past. I learned it when I was an undergraduate student. It was part of AM care and PM care, but that is not the case anymore. However, reducing the bacterial burden in the mouth through consistent oral care is associated with a significant reduction in the incidence of NVHAP. Next slide, please. And I'm going to give you an amazing quality improvement example. Sean spoke about quality improvement. Well, the exemplar that I can give you is from the VA. But basically, this is the protocol. It is an oral hygiene. It is a nursing care protocol that has been adopted as a standard of care in the entire VA system. Started in one hospital in VA hospital in Salem, Virginia, and now scaled to the entire 155 hospital and long-term care settings of the VA health system. So it can be implemented by a nurse. It can be implemented under the supervision of a nurse and delegated to a nursing assistant. It is definitely a doable oral hygiene protocol. Next slide, please. And the VA, and I was on the National Advisory Board that established the NOHAP, the National Organization for the Prevention of Hospital-Acquired Pneumonia, non-ventilator hospital-acquired pneumonia. But it started with engaging nurses in Project Happen. There is a whole website for it with all kinds of information. But basically, next slide, please. The protocol assesses every patient to determine what their level of self-care is, ranging from self-care to self-care and staff assist to totally dependent for their oral care. But the protocol includes a swallow test assessment first by the speech and language pathologist to determine if a bite block is required and if additional swallow assessment is required because the person will swallow water and will have their teeth brushed. They always use PPE when assisting patients with mouth care, or hand hygiene, of course, to prevent the transmission of bacteria from patient to patient, documenting their oral care in the patient record, and using disposable oral swabs does not cut it, and it does not replace toothbrushing. They are for comfort only, one-time use, and do not leave them soaking in a cup for use later. They are one use and dispose. And then they maintain adequate oral hydration throughout the 24-hour period. And dentures, which often go missing in hospitals, are to be cleaned before the patient goes to bed, removed and then cleaned and placed in a safe environment. This is the protocol. It's really simple. And it has been shown, there have been numerous quality improvement studies that have been done. And I'll just give you, and we're going to show you articles that you can read. Next slide, please. About integrating oral health into patient management to prevent hospital-acquired pneumonia. So as of December 18th in this 2018, and this is one snapshot, 8 VA hospitals in North Carolina, Texas, and Virginia reported that an estimated 172 cases of NVHAP were prevented, 31 lives were saved, and $6.8 million in cost avoidance occurred. And you can imagine if you multiply these 8 by the 155 hospitals to which it, and long-term care facilities to which it has, this protocol has now been scaled as a standard of care, and the effectiveness of the outcome data attracted the interest, as you can see from the middle, quick safety one pager of the Joint Commission, which is the a creditor, if you will, of all hospitals, just about every hospital and many outpatient practices across the country, that issued this special alert about the importance of preventing NV-HAP through the use of oral hygiene. And two other things. The VA has partnered with Press Ganey, and there have been SNOMED terms established for standardized terms for the inclusion of oral hygiene in electronic health records. That is the medical electronic health record, so that oral hygiene can now be a standardized documentation term in all settings. And this is not just for the VA, this is nationwide. And one final thing about this, because it's so exciting, is that there is, the VA is negotiating with Press Ganey, which controls all the hospital satisfaction and the nursing database of quality indicators, for oral hygiene to become a quality outcome indicator. This would have nationwide impact immediately, because it would be a required reporting quality indicator reporting requirement for all hospitals nationwide. So very exciting. We're not always saying there's a big gap, but that we can move forward in significant and high impact ways. Next slide, please. So this is just a summary of what I said. So let's move on. I will only say that 3 mentions in the new Oral Health in America report mentioned oral health 3 times and NV-HAP. And in the National League for Nursing, this is in the nursing community, that the Advancing Care Excellent web-based series, accessible to the 40,000 nursing members of the National League for Nursing, features oral health in their ACE Senior, their ACE Pediatric, their ACE now in ACE Disability, ACE Veterans, and ACE Alzheimer's. There are oral health teaching learning strategies in those, and one of them is about NV-HAP. I'm happy to say you can go to the NLN website. They are open access web-based resources across professions, and they are written into professionally, I will say. So all good. Next slide, please. Okay, our last chronic condition, cancer and oral health. Anne-Marie's story is not an unusual one. Her treatment for lymphoma was going smoothly. She appeared to be responding, but she did not have an oral health assessment before starting her chemotherapy, which we all know is immunosuppressive. She's now on day 14. She has a fever and hypotension requiring admission to the hospital. She is started on antibiotics and blood culture. And this is the first time the oncology team in the hospital inspects her oral cavity. They did not do a he-nod exam, and they find thrush, poor dentition, and evidence of periodontal disease. This is the likely source of the sepsis that they found on culture. Now, she was treated vigorously, very assertively, but her treatment was delayed due to the urgent need for dental treatment, oral health treatment. And you know what? You never know for how long and whether this will impact her, her chance of a cure. We know and recommend, next slide, please, that an oral assessment will absolutely should be the standard of care and treatment prior to beginning any oncology treatment, because we know that it is immunosuppressive and patients are at much greater risk for infection that can locate in the mouth through mucositis, herpetic lesions, other kinds of oral, not to mention xerostomia as well, and travel to other parts of the body and contribute to sepsis, which of course can be fatal. And the one thing I want to stress for the dental members of the audience, as was so evident in the previous presentation, is that often the dental office is a point of assessment and diagnosis for cancer. And I'm not talking about head and neck cancer only, although it is for that, but for systemic cancers like leukemia, lymphoma, and whether it's lymphedema, whether it's bleeding gums, oozing gums, or whatever, it is often a setting for assessment and diagnosis. And we know, we spoke about chemotherapy, but that radiation and bone modifying agents like the biphosphonates and immunotherapy have multiple side effects that impact oral health and overall health for oncology patients. And next slide, please. And so some of the oral side effects that both oncology providers, primary providers, and dental providers need to pay attention to are these, and they can be caused by either chemotherapy or radiation therapy. Next slide, please. But the good news is we can collaborate to manage treatment-related symptoms, and digital therapeutics like the GOMO Health digital app for cancer treatment that includes oral health, believe it or not. Our ONEP team collaborated with them. This can be used to promote self-service solutions, monitoring of patient side effects. It is a digital vehicle for escalating the need for different kinds of specialty care providers, not just being able to activate your own self-management strategies, but also it's a great example of the future in terms of virtual care. And these are some of the collaborative strategies to manage treatment-related symptoms that are in the GOMO digital app that patients can use to manage their oral side effects, both to prevent side effects of chemo, like mucositis or other types of lesions, or more periodontal or gingivitis type of symptoms, or those related to xerostomia. And that has been adopted as an outpatient self-care strategy by 10 cancer centers nationwide, including the Cancer Treatment Centers of America. So you can Google them and find out more about them. Next slide, please. So it takes a village to promote effective cancer care. And here's an example of a little diagram we made of who, and often it's more than one profession, that can play a leadership role or a partnership role in helping to manage the oral health side effects of cancer care. And when you look at limited hand mobility, you say, what is that doing here? Well, the patient could have neuropathy and numbness and tingling and have difficulty holding a toothbrush and may need an adaptive device to perform their own oral hygiene. So this is a good example of how it takes a professional village to manage cancer care in an effective way. Next slide, please. And it goes without saying, of course, that we are proponents of all medical providers performing an HENOT exam that would be part of or include the oral cancer screening during primary and specialty care visits. We know that oropharyngeal cancer has increased, especially in young men related to HPV. And so both an intra and extraoral exam is extremely important in oral cancer screenings and to bring that into better epidemiological control. Next slide, please. And of course, we can all advocate for HPV vaccines on the primary care side. Up to age 45, we can advocate and administer and improve oral health literacy and cancer literacy for, advocating for use of the HPV vaccine. But even though you're not administering it in a dental setting, you certainly can be contributing to the oral health literacy and advocacy for it. And we have found, next slide, please, that if it's positioned as a cancer prevention vaccine, rather than something related to sex, S-E-X, then it's much more acceptable to parents of preteens and teens who are very prickly about having those conversations either with a dentist or with their child's or adolescent's medical provider. So here are the vaccine recommendations, and everybody should know what they are in terms of preventing oral cancer related to HPV. Next slide, please. And then for those who do get oropharyngeal cancer, some of the side effects that we spoke about, or after effects that we spoke about earlier in It Takes a Village, are those that we need to manage for these patients. And hopefully with the new Medicare dental benefit, if it's authorized, they will have a more extensive array of dental services available to them, especially if they are older. Next slide, please. And we just wrote an article in the Journal of Dental Education advocating for interprofessional education and practice collaboration to address these rising rates of oropharyngeal cancer related to HPV. Next slide, please. And a blog that we just wrote, an ONEP blog that we just wrote. Next slide, please. And then here are a few resources. We have an undergraduate interprofessional oral health faculty toolkit that covers every undergraduate nursing course that could possibly be taught, where we integrate oral health bites into an existing curriculum so that there's no need for a new course, an elective or required or anything, but we slip it in when we integrate it, when we're teaching about diabetes, pregnancy, heart disease, mental health, or any of the conditions, chronic, acute, or otherwise, in an undergraduate program that a registered nurse would encounter. Next slide, please. Next slide, please. And these are graduate toolkits that address the curriculum of each of the nurse practitioner programs, as well as midwifery, that are very course specific, related to health promotion, assessment, and management of child or adult or women's health primary care problems. Next slide, please. And these are some oral health literary products that we produced in partnership with the American College of Physicians that are intended for use in primary care settings. And believe me, they're good for increasing the oral health literacy of the health professionals in those settings, as well as the patients. They're really very good. English and Spanish, written at the 6th grade level. You can access them from our website and print them out. Next slide, please. And then we have case study resource kits that we've produced that are very interprofessional, and they're really unfolding case studies. And some of them cover the entire family and the entire lifespan, from pregnancy through older age, chronic illness, dementia, etc. Next slide, please. All of these are open access. And as Sean mentioned, Smiles for Life is the cornerstone curriculum for interprofessional use, and endorsed by all professions, with free CEs offered for completion of each module. And the one on the older adult and the first one on the oral systemic connection are excellent for addressing management of chronic conditions. Next slide, please. So it truly takes a partnership to prevent and effectively manage chronic conditions from the perspective of oral systemic health. There is so much room for us practicing together to have a collaborative relationship and a collaborative impact, high impact, on promoting the oral health and overall health of, and children do have chronic conditions, children, but especially adults, as we've discussed today, who have chronic conditions. So thank you very much. And I don't think we have, because of that snafu, any time for questions. And here are 2 pages of references.
Thank you so much, Dr. Haber, and right on the nose too. What a great informative presentation. I really enjoyed that. So much for presenting for us today. We so appreciate your time.